We just got off the shock call, and the team has made the decision to cannulate for VA-ECMO. Briefly, this is a 36-year-old man presenting with chest pain, dynamic EKG changes, and severe biventricular failure with normal LV and RV cavity size. He is hypotensive, hypoxic, lethargic, and cool to touch. Hello, CardioNerds CathMasters. Welcome to this Data to Delivery episode where we will discuss the what, when, why, and where for VA-ECMO. Stay tuned for the upcoming Proctor's Playbook episode in which we will discuss the how and the crisis control episode in which we discuss the approach to complications. This is Nazli Okumus, chair of the CardioNerds Interventional Cardiology Council, and I'm here with Drs. Dan Ambinder, Dr. Gage, and Dr. Marwan Jumean.
Team, VA-ECMO, decision-making, cannulation, and management are some of the most complex care we offer. So in our pursuit of mastery in the cath lab, we brought in some extraordinary CathMasters to teach us today. First, Dr. Gage is an interventional cardiologist at Centennial Heart in Nashville and a founding member of the Society of Critical Care Cardiology, National Physician Director for ECMO for HCA, the Hospital Corporation of America. She is a national leader at the intersection of interventional cardiology and critical care. A true CardioNerds veteran, we love hanging out with her on the podcast and in person at conferences across the country. Welcome, Ann.
Dan, that was much too kind of an introduction. Thank you. Hi, CardioNerds family. I am so excited to spend some time with this group of experts discussing VA-ECMO. It's definitely a favorite topic of mine. So thank you to Dan and Amit for this invitation.
Really our treat. And now let's welcome Dr. Marwan Jumean, an interventional structural cardiologist at UT Health Houston, director of the Interventional Heart Failure Fellowship Program, and founder of the Houston Shock Symposium. Welcome, Marwan.
Thank you very much for the kind invitation. I'm really excited to be with you guys today and discuss ECMO and everything related to it.
Okay, it's time to start with a case. We just got off the shock call, and the team has made the decision to cannulate for VA-ECMO. Briefly, this is a 36-year-old man presenting with chest pain, dynamic EKG changes, and severe biventricular failure with normal LV and RV cavity size. He is hypotensive, hypoxic, lethargic, and cool to touch. Coronary angiography shows normal course, and right heart cath revealed elevated IV filling pressures and low cardiac output. He is having escalating salvos of NSVT. The team has asked us to cannulate for VA-ECMO for presumed fulminant myocarditis. As we activate the cath lab, let's make sure we are all on the same page. And briefly, what is the anatomy of the VA-ECMO circuit?
All right, we have a big task ahead of us. We need to help save the life of this 36-year-old man. So let's become experts on VA-ECMO quickly. So ECMO comes in two mechanistically distinct forms, veno-arterial or veno-venous. And for today's discussion, we're just going to limit our discussion to veno-arterial ECMO. So before we describe the circuit or the machinery itself, we need to make sure we understand what ECMO is and why it might be a physiologic benefit for our patient. ECMO stands for extracorporeal membrane oxygenation. At the most basic level, VA-ECMO is a machine that does the work of the heart and the lungs. This means it has the ability to support the entire cardiac output and perform gas exchange, both oxygenation and ventilation. So with VA-ECMO, we can normalize PCO2, PO2, and pH. And when discussing ECMO, we talk about the circuit, which is the entire machine used to perform extracorporeal membrane oxygenation. There are multiple components, all of which together comprise this ECMO circuit. You can think of this as the path traveled by a single red blood cell from the time it exits the body to its re-entry into the arterial circulation. Everything the single red blood cell contacts can be considered part of the ECMO circuit. So in a VA-ECMO circuit, deoxygenated blood is pulled from the venous circulation by a pump via a large bore venous cannula. Blood passes through the pump and then travels into an oxygenator. Here, gas exchange occurs. Oxygenated blood then travels through another large bore cannula to be returned to the arterial circulation. This path from the entry of blood at the level of the venous circulation to return at the level of the arterial circulation encompasses the ECMO circuit. This terminology with the ECMO circuit can be confusing. There are ultimately two large bore cannulas, one of which pulls blood from the body, while the second cannula returns blood to the body. Most commonly, these cannulas are referred to in one of three ways. They may be called the venous and arterial cannulas. That's one option. Or they may be called the inflow and outflow cannulas. It's another. Or they could be called the drainage and the return cannulas. That would be our third option. So what does the machine look like? Well, if some of you have may have heard me say this before, but I think it is helpful to think of yourself as the ECMO circuit. So you are the central hub, and each of your arms is a large bore cannula. Your left arm drains blood from the patient's venous system and can be referred to as the venous, the inflow, or the drainage cannula. Your body then represents the pump and the oxygenator, and your right arm represents the cannula delivering oxygenated blood to the arterial system of the body. And this can be referred to in one of these three ways: the arterial cannula, the outflow cannula, or the return cannula. Inflow and outflow cannula can sometimes get a little confusing, but ECMO is an egotistical machine. You're talking about inflow into the ECMO machine and out of the ECMO machine. And so this serves as the point of reference for describing the direction blood is flowing. Veno-arterial ECMO is placed either peripherally or centrally, and this refers to the method by which cannula are inserted and where they're placed. Peripherally inserted ECMO is placed percutaneously using a Seldinger technique, usually by an interventional cardiologist, a surgeon, or a critical care physician. And centrally cannulated ECMO requires anastomosis of the cannula to a blood vessel within the chest and is most frequently used in post-cardiotomy patients. As such, this is usually placed by a cardiac surgeon. So ECMO circuits can have multiple configurations. In the most typical VA configuration, a venous drainage cannula is placed via the common femoral vein, and the tip of the cannula is placed near the SVC and RA junction, and the arterial or return cannula is placed via the common femoral artery with the cannula tip in the descending aorta. This configuration is sometimes modified to the point of entry for the venous cannula is the internal jugular, and the arterial cannula is the axillary artery. It is also possible to have percutaneously placed left atrial VA ECMO. In this configuration, the venous inflow cannula enters the body via the common femoral vein and then traverses the interatrial septum and is then placed with the tip in the left atrium. This is most commonly performed using a proprietary tandem heart system or with a multi-stage cannula. That means it has fenestrations in multiple places, and that can have the ability to drain both the left atrium and the right atrium. So for our patient, the one we've left dying to give this little discussion on ECMO, you have told us that he has biventricular failure and is hypoxemic. VA ECMO has the ability to provide both biventricular support and oxygenation, and it can be deployed in a rapid fashion, perhaps making this an ideal strategy for this patient.
Thanks, Anne. So now that we have become really familiar with the anatomy and terminology of VA ECMO, when should we be pulling the trigger to use it? So Marwan, let's turn to you. What are some of the indications and contraindications for VA ECMO cannulation?
Okay. VA ECMO in general is indicated for acute, potentially reversible cardiac or cardiopulmonary failure when conventional therapies have failed. And the way I think about VA ECMO is I need to temporarily support the patient immediately in patients with cardiogenic shock, especially stage D or E in extremis, or in cases of ECPR. The scenario of this young with biventricular failure because of myocarditis, that would be an indication to support this patient. Other examples of cardiogenic shock include post-cardiotomy shock patients, acute decompensated biventricular failure, and cases of ECPR. Another rising indication for VA ECMO because of the advent of teams across the country, massive PE would be a potential indication as a bridge. And we have to remember VA ECMO, like other temporary support devices, are only a bridge to a definitive therapy, whether it's revascularization, thrombectomy, or immunosuppressive therapy. With respect to the contraindications, really, it's all relative. But for me, number one, I think about access. So if it's severe peripheral vascular disease, I cannot cannulate the patient peripherally, then probably I can't do VA ECMO. There is multi-organ failure that I think that VA ECMO is too late to support the patient. If there's advanced malignancy or an irreversible neurological damage or an underlying condition, I cannot treat with VA ECMO to a potential for recovery or definitive therapy.
Thanks for walking us through who the right candidates are for VA ECMO. We know from the ELSO registry that VA ECMO utilization has been skyrocketing in recent years, likely with improvements in technology and availability. Yet, outcomes generally remain quite poor and unchanged. And can you go over data around use of VA ECMO for different indications?
Absolutely. So much of what we know about ECMO utilization and outcomes comes from the Extracorporeal Life Support Organization, or ELSO, and its registry. Hospitals can become ELSO centers and contribute their data to the ELSO registry. ECMO utilization has increased over time, most recently, obviously, driven by an increase in adult utilization with an explosion in use during the COVID-19 pandemic. As of 2022, also reports an overall survival to hospital discharge of 44% for adult cardiac patients receiving VA-ECMO. We have multiple studies that highlight the importance of the underlying diagnosis in determining survival. In general, patients with potentially reversible causes of myocardial injury, such as fulminant myocarditis or primary graft failure after orthotopic heart transplant, have better survival than patients with cardiogenic shock after acute myocardial infarction. Post-cardiotomy cardiogenic shock patients have especially poor survival on ECMO. Their published mortality rates are often in the range of 64 to greater than 75%. So in addition to underlying diagnoses, pre-ECMO risk factors independently associated with poor outcomes include some of the obvious, but older age, female sex, a higher body mass index, as well as markers of illness severity, including renal, hepatic, or central nervous dysfunction, longer duration of mechanical ventilation before ECMO deployment, elevated serum lactate levels, and reduced prothrombin activity. There are actually risk scores that incorporate these variables to aid in decision-making regarding utility versus futility of ECMO. And the veno-arterial ECMO SAVE, S-A-V-E score, is the most widely cited risk score and stratifies patients based on diagnosis, their age, weight, pre-ECMO organ function, or organ failure, and duration of intubation pre-ECMO. As far as the actual trial data, though, unfortunately, randomized controlled trial data for VA-ECMO has largely been negative. In 2023, ECLS shock was published. This trial randomized AMI cardiogenic shock patients to VA-ECMO versus standard of care. 92% of patients were cannulated during their initial presentation to the cath lab. ECLS shock showed no difference in outcomes between standard of care and those patients cannulated on VA-ECMO. Subsequent to this, ECMO CS, also published in 2023, showed no difference in outcomes when patients with multiple etiologies for cardiogenic shock were randomized to early deployment of VA-ECMO. I should at least mention ECPR here, or extracorporeal cardiopulmonary resuscitation. So this is when a patient with refractory cardiac arrest and ongoing CPR is cannulated for VA-ECMO. The jury is actually still out on the data for ECPR, with the Inception trial in the Netherlands and the Prague ECPR trials both showing no improvement in survival among patients with refractory out-of-hospital cardiac arrest when they're randomized to ECPR rather than conventional CPR. In these studies, survival was less than 30% in both groups. This data is challenged by the ARREST trial, which was performed by some of our colleagues at the University of Minnesota. And this showed that early ECMO-facilitated resuscitation for patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation significantly improved survival to hospital discharge compared with standard ACLS treatment. In the ARREST trial, survival for the ECPR group was 43%.
And thank you for elaborating further on survival outcomes with VA-ECMO and ECPR. Does every patient need, or we could also say deserve, mechanical unloading with an intra-aortic balloon pump or percutaneous LVAD?
Oh, Nazli, this makes me so excited. I'm so happy you asked this question about mechanical unloading. Within the cardiogenic shock and mechanical circulatory support world, this is a hotly debated topic, and I, of course, have some opinions. So it challenges our understanding of cardiovascular hemodynamics in a very nuanced way, and it is currently controversial and provocative. This all makes for a great nerdy debate among cardiologists, especially those of us that like ECMO. So the premise of your question is whether patients on VA-ECMO suffer deleterious hemodynamic consequences from the circuit itself, such that another device is needed to counteract these hemodynamic insults. Specifically, if VA-ECMO increases LV afterload, is an intra-aortic balloon pump needed to help lower afterload, or a microaxial flow pump, such as the Impella, needed to directly unload the LV. So I was actually asked about this on a 2022 episode of CardioNerds, and I went back and listened to my answer. We all evolve a little, and I won't get into it verbatim, but I said something like this. Repeat this over and over. ECMO increases LV afterload. ECMO increases LV afterload. And I will stick by this comment. Most data and experts agree that VA-ECMO increases afterload. The concern is that in the face of increased afterload, left ventricular volume and pressures may rise, subsequently increasing the left atrial pressure and the pulmonary artery occlusion pressure. If this occurs, there could then be an increase in myocardial oxygen demand, which might worsen LV function, the exact physiology that we are hoping to avoid in patients with acute cardiogenic shock, especially those with acute ischemic insults such as acute myocardial infarction or active ischemia. So this series of hemodynamic consequences has widely been accepted and has served as the reasoning for mechanical unloading devices to help counteract the potential negative effects of increased afterload on the LV. However, there is an increasing amount of data, so my answer may be slightly different than 3 years ago, that left-sided filling pressures do not always rise in the setting of increased afterload. We have to remember that the ECMO venous drainage cannula is directly draining blood from the right side of the heart, such that there may be a decrease in the RA preload and RV stroke volume, all of which would lead to less filling of the left ventricle. Perhaps, at least in some patients, this physiology may counterbalance the increase in afterload. Think about the Starling curve for a moment. If you are on the ascending limb of this curve, your stroke volume is dependent on your preload. If you decrease your preload to a healthy right ventricle, your stroke volume will go down and the LV will not see as much blood. The University of Minnesota group led by Dr. Kalra has published about this, demonstrating that with in vivo data, that the physiology may not be as simple as LV afterload rises, LV pressure and volume increase, LV distends, stroke volume decreases, aortic valve fails to open and stasis and badness ensues. Rather, it is likely that the loading conditions and the underlying contractility of both ventricles play into LV hemodynamics on VA-ECMO. So I guess the answer to this question is likely that not every patient requires mechanical unloading, and we really need to be careful about the physiology in front of us. That being said, most of us will likely deploy an upfront unloading strategy due to practical considerations. So if the patient is in the cath lab for ECMO deployment or another procedure immediately after cannulation, we frequently place these devices so the patient does not have to repeatedly travel on ECMO.
And thanks so much for sharing your insights, perspectives, and evolving thoughts on LV unloading and this great debate. I think I've been hearing about this debate for the last 10 years, and it is still really exciting to hear about because it ties in physiology and also mechanical circulation all together. But that brings us to our next question. Marwan, as you and Anne have highlighted, these are clearly complex and nuanced decisions and really takes a team to sort through how to deal with this on a broad program level, but also on an individualized patient level. So how does the shock team factor into this?
Thank you. But I want to add to the previous topic about unloading. It's not just the cannula size, but we also know that patients in shock, there's a lot of changes that happen hour to hour and day to day. So the status of the left ventricle, the right ventricle, the background medical therapy also play a role in whether there is an increase in the LV ADP, LV afterload, and the need for unloading. And one thing that is not fully looked at is the goal for VA-ECMO deployment, whether it's to allow the LV to recover because of an incident such as an acute myocardial infarction with, let's say, VT or VF arrest, or is it because of advanced heart failure and this patient requires a heart transplant? So whether we're looking at LV recovery versus LV replacement therapy, and the decision on whether we need to unload also may vary based on that. Anyways, I digress with respect to shock team. Shock teams play a really important role in the decision-making of placing someone on VA-ECMO or any percutaneous support devices. It provides early recognition, evaluation, and management of cardiogenic shock. We know that having a shock team is superior to not having a shock team, likely because of these factors: the early and increased use of PA catheters, invasive hemodynamic monitoring, and use of higher support devices on those patients. And there are several data out there from the cardiogenic shock working group, from Innova, and others showing that there is an improvement in patients' outcomes when there is a shock team approach. And the shock team is not just one individual. It's an interventional cardiologist, a heart failure cardiologist, a cardiac surgeon, a critical care physician, anesthesiologist, and looking at the local resources within the system and using all that to deploy support for patients early on and manage them at a shock center.
Marwan, thank you for sharing your approach to the ongoing debate about LV unloading and breaking down the critical role of shock team. It is so helpful to understand how the shock team factors into these critical decisions. And everyone has a different approach to counseling and consenting. Can you please describe your approach to counseling the family members when consenting for VA-ECMO cannulation?
Sure. So, in an ideal situation, we would all always prefer to obtain consent from the patient undergoing a procedure rather than a family member. But in the case of ECMO, this is frequently not possible. So I begin my consent, probably like many of you do, by providing a simple description of VA-ECMO. This is something like, my recommendation is that your loved one be placed on a machine known as VA-ECMO. This is a form of full life support that can do the work of the heart and lungs for days to weeks. Most families look at me terrified at this point, and I'm not sure what they hear after I say these words, but I continue with something like, in this situation, the indication to do this procedure is to support the heart and maintain the function of the other organs in the body, which rely on the blood flow of the heart. I then walk the decision maker through the process of placing the cannulas in the groin and what this machine looks like. We go through some of the risks and say these procedures are not without risk. There are large tubes that can impair blood flow to the legs and risk the health of the legs. Patients can experience life-threatening bleeding or strokes, in addition to other complications. I will say that frequently the overall survival is reported at less than 50%, but that doesn't take into account all the factors for your loved one. And so we may have higher rates of survival. I then walk them through that the benefit of this is that it may allow us time to provide additional treatments that help the heart recover its function or maintain stability of the remainder of the body's organs in the event that the heart does not recover, and we may need to consider permanent heart pumps or heart transplant. The alternative, which I think is important to discuss, especially given the kind of data in this area, is I say that all our alternative is that we continue to use medications to try and help achieve these same goals. And I think that it's especially important when you're deploying such a resource-intense therapy that loved ones have some expectations of what an ECMO run can look like. I stress that there's often a period of attempted stabilization, and in the best case, we get to recovery, but that if they don't stabilize or recover, that these machines can be used for days to weeks while we evaluate for additional therapies. And that often this looks like they're spending maybe 1 to 3 weeks in the cardiac intensive care unit and perhaps many more weeks in a rehab facility. And so obviously one of the challenges we face in this patient population is that they're often transferred to us very ill and perhaps ventilated and unable to communicate. And they land in our cath lab ready for immediate treatment, where making informed consent is obviously a challenge. So I think it's important, or actually imperative, that we understand the patient's premorbid condition when possible, and if this treatment, VA-ECMO, is in line with how they would like to be cared for. And so one of the things that we have found helpful at my hospital is that our shock team utilizes our ECMO coordinator. Her name is Jamie. She deserves a shout out because she has made this such a great process for us. She is the information gatherer for us from the moment we are contacted about a potential ECMO transfer or we're activated within our own hospital. She immediately contacts the patient's POA and begins asking questions about this patient to help us gain insight into the patient, his or her premorbid condition, and his or her wishes prior to the patient's arrival at our hospital. She also uses this time to introduce the mechanical circulatory support, which allows them some time to begin to process all of this before they actually meet the physicians who are seeking informed consent.
And I'm so glad that you brought up Jamie, your ECMO coordinator, because it really highlights that we have two things going on here. Time really matters, but at the same time, understanding where the patient's coming from, where the family members are, and that consent process is also really important. And they may conflict at times, but realizing that you have a larger team that's acting in concert so that you could achieve all the goals that you need to achieve, saving the patient or at least optimizing the patient as much as you can. While at the same time, you have a group of people that are focused on just making sure that the whole thing's appropriate, gathering everything. So we really appreciate that it's not just about cannulating the patient and putting them on an ECMO, but it really requires a whole holistic approach to each one of these patients. And so I'm really glad that you mentioned the broader team when it comes specifically to this kind of conversation. So Anne and Marwan, thank you both for walking us through the core principles of VA-ECMO, from anatomy and indications to the crucial role of the shock team, the consent conversation. This foundational knowledge sets the stage for what comes next in our series. So for our listeners, stay tuned for the next episodes in this series, because we're going to be diving into the technical aspects of cannulation and how to manage complications when things don't go as planned. Stay tuned.